to the next point. Atrophic gastritis, where the gastric epithelium, that is parietal cells, intrinsic factors, chief cells, all of them are atrophied, can result in decreased formation of HCl, that is hypochlorhydria, inadequate intrinsic factor production, that is decreased amount of vitamin B12 synthesis, vitamin B12 activation rather, and therefore causing vitamin B12 deficiency and increased methylmalonic acid level. So atrophic gastritis is indirectly linked to methylmalonic acid, and the reticulocyte count increased dramatically once vitamin B12 replacement therapy is initiated in an individual with pernicious anemia. Hemoglobin erythrocyte levels rise more gradually, so more faster increments in the number of reticulocytes, while the mature form of the RBC, that erythrocyte count as well as the hemoglobin rise is much gradual, which takes 8 weeks to almost 3 months to normalize. So now, next one is about hemolytic uremic syndrome. Hemolytic uremic syndrome manifests as AKI. So there is hemolysis, therefore there is microangiopathic hemolytic anemia. Then there is AKI. Those anemic, RBCs fragments goes to the kidney and cause AKI as well as thrombocytopenia. Characteristic laboratory abnormalities include decreased hemoglobin and platelet count. Thrombocytopenia, as the number says, there is hemolytic anemia. So anemia means decreased hemoglobin, and thrombocytopenia means decreased platelet count and increased. So the platelet count is increased, but due to uremia is decreased. But due to uremia, only the VT, the quality it causes qualitative platelet disorder, causing increase in bleeding time. And because there is hemolysis, LDS, bilirubin, blood urea, nitrous, and creat, all of them increase. Next point is about dactylitis. Dactylitis occurs in sickle cell disease. Painful swelling of the hands and feet is a common presentation of sickle cell disease in young children. So especially in young children, dactylitis is very common. It's one of the many vaso-occlusive manifestations of sickle cell disease, including acute chest syndrome. Sibling episode result in hemolysis, which leads to increased indirect bilirubin production and lactase dehydrogenase. LDS also increase, as well as decreased amount of haptoglobin. So haptoglobin binds to the broken fragments of hemoglobin, of RBC, that is onto the hemoglobin, thereby decreasing its count in the blood. So methotrexate inhibits DHFR, that is dihydrofolate reductase. So it is a vitamin B9 antagonist used in the treatment of ectopic pregnancy. So in ectopic pregnancy, this methotrexate is given in some intervals, like in 7 days, and there's a whole sequence of days where methotrexate is given to control ectopic pregnancy as well as choriocarcinoma as well. It competitively inhibits the enzyme DHFR, so dihydrofolate reductase, which catalyzes this of THF, so tetrahydrofolate. So dihydrofolate is not converted to tetrahydrofolate, therefore DUMP is not converted to DTMP. So there is thymidylate deficiency, and thymine deficiency alters the maturation of or the replication of DNA. So DNA replication does not occur. Okay. So DHFR inhibition causes intermediate DHF dihydrofolate to accumulate intercellularly. Now, next point is about the presence of erythroid precursors in organs. So that's liver and spleen is indicative of EMS. So erythroid precursors in organs, such as the liver and spleen, is indicative of EMS. So EMS, I guess EMS is erythroid precursors. EMS. So let me search about it. Extramedullary hematopoiesis. Okay. So EMS means extramedullary hematopoiesis. So extramedullary, not inside the bone marrow, but the synthesis of hemoglobin, the hematopoiesis, all hemoglobin, WBC, RBCs, platelets, all of them are synthesized now not in the bone marrow, but in liver and spleen. So the presence of erythroid precursors in organs such as liver and spleen. So if there are erythroid precursors, means the immature form of the erythrocytes, RBCs, in the liver and spleen, it is indicative of extramedullary hematopoiesis, a condition characterized by EPO stimulation by the kidney. So kidney release EPO, hyperplastic marrow cell invasion of extramedullary organs. So hyperplastic marrow cell invasion of extramedullary organs, and extramedullary hematopoiesis is most frequently caused by severe chronic hemolytic anemias such as beta thalassemia. So extramedullary hematopoiesis is most frequently caused by severe chronic hemolytic anemia. So severe chronic hemolytic anemia such as beta thalassemia causes. So in beta thalassemia, there is a kind of anemia, iron deficiency anemia. So iron deficiency anemia uh, occurs, and there is hemoglobin. There's a defect in hemoglobin, in the globin gene during in thalassemia, and extramedullary hematopoiesis is most frequently caused by severe chronic hemolytic anemia. So any chronic hemolytic condition where there is anemia results in kidney secreting more EPO. So that is erythropoietin, which increases the erythroid precursors in extramedullary organs, thereby causing extramedullary hematopoiesis. Okay, the triad of low hemoglobin, thrombocytopenia, and absent SPO cells in the bone marrow is consistent with aplastic anemia. So in aplastic anemia, there is decreased platelets, decrease hemoglobin, and absent SPO cells. So hematopoietic stem cells. So SPO cells are stem cells. So SPO cells are referred to. So decreased amount of hematopoietic stem cells. Hematopoietic stem cells, decreased amount of platelets, decreased amount of RBCs, that is low hemoglobin. So hemoglobin, platelets, and absent SPO cells in the bone marrow is consistent with aplastic anemia. A compensatory increase because of decreased hemoglobin, so anemia, decreased RBCs in the blood because of anemia. More EPO, that is erythropoietin levels, is expected in individuals with aplastic anemia and normal renal function. So renal function is not impaired. However, the kidneys secrete a hormone called EPO, that is erythropoietin, in response to the decreased hemoglobin count in the body. Okay, red Steinberg cells. So they are owl-shaped, so owl-sized, like the cells. So their nucleus are owl's eyed shaped. So red Steinberg cells are large binuclear cells with an owl's eyes appearance that appear on the background of lymphocytic infiltrates. So they appear on a background of lymphocytic infiltrates. Red Steinberg cells must be present histopathologically. So they must be present to diagnose SL, that is Hodgkin's lymphoma. So they appear on the background of lymphocytic infiltrates. So in any sort of lymphoma or leukemia, if there is a background, then the background is usually of leukocytes or lymphocytes. So lymphocytic infiltrates are appear in the background, while red Steinberg cells, the characteristic cells of Hodgkin's lymphoma, appear dominantly. Okay, next point is coarse erythrocytic basophilic stippling and microcytic hypochromic anemia are common common previous findings of lead poisoning. So lead poisoning causes hypochromic anemia, microcytic hypochromic anemia, and basophilic stippling. So high risk groups include young children ingesting paint chips. Okay, paint chips, and industrial workers inhaling particulate lead. Okay, this is a very general point, and it has been discussed before as well. Adhesion of cells to the extracellular matrix involves integrin-mediated binding to fibronectin, collagen, and laminin. So adhesion of cells to the extracellular matrix. So if cells adhere to extracellular matrix, so there is an extracellular matrix which is made up of, let's say, collagen. So collagen and fibronectin or laminin. So in the extracellular matrix, it is a matrix formed of collagen and collagen, fibronectin, and laminin. So this forms extracellular matrix, and though the cells adhere to those extracellular matrix via integrin. So integrin is a binding molecule, and differential expression of integrin subtypes affects the adhesion properties of individual cells and has been found to correlate with malignant behaviors of a number of tumors. So there are various subtypes of integrin that helps in the attachment, that gives specificity of a cell to attaching to the attachment into the extracellular matrix, because some subtype of integrin can bind to collagen, some subtypes can bind to fibronectin, and some of them can to laminin. And therefore the malignant behaviors of a number of tumors, is largely dependent on the subtype of integrins present in their cell surface. Okay, the next point is the key the key GFs that promote growth factors that promote angiogenesis in neoplastic and granulation tissues. So in neoplasia, let's say in retinoblastoma, or let's say wherever there is increased proliferation of blood vessels into the cancer cells, for cancer cells to multiply independently, there is increased expression of growth factors like fibroblast growth factors, and VEGF. So bevacizumab is a monoclonal antibody which decreases the number of, or synthesis of VEGF, decreases the growth factor, vascular endothelial growth factor. So the key growth factor that promote angiogenesis in neoplastic and granulation tissues are VEGF and FGF. So pro-inflammatory cytokines that interleukin-1, interferon-gamma can indirectly promote angiogenesis through increased VEGF expression. So pro-inflammatory cytokines, that is interleukin-1, interferon-gamma. So interleukin-1, interferon-gamma, interferon-gamma. So pro-inflammation, the inflammation-causing cytokines are interleukin-1, interferon-gamma. They can indirectly promote angiogenesis through increased VEGF expression. So these interleukins increase the VEGF expression by the cancer cells. Therefore, there is more neogenesis into the cancer cells. The tissues where the cancer cells are present have high blood flow because of the interleukins, or let's say interferon-gamma, that which are the pro-inflammatory cytokines that promote angiogenesis through increased VEGF expression. So the laminin in the basement membrane may pose a physical barrier to the sprouting of new blood vessels. So one of the toughest structures for blood vessel to pierce is laminin that is present in the basement membrane. So in the basement membrane there is a structure called laminin, and this laminin pose a physical barrier to the sprouting of new blood vessels. So okay. So now next point is about pudiorin's appearance. Pudiorin's appearance is an erythematous itchy breast rash with skin texture changes that resemble an orange peel. So just like an orange, there is erythema or redness, including itchy breast rash. There's a rash which is very itchy. The rash is red, when there are some skin texture changes which resemble an orange peel. So it is a key dermatological presentation of inflammatory breast cancer. So if there is any sort of inflammation in the breast, so inflammation causes reddening, so which is the same pudiorin's appearance. Therefore, inflammatory breast cancer and cancer spreading to the dermal lymphatic space and obstructing the lymphatic drainage results in pudiorin's appearance. So those cancers which obstruct the lymphatic drainage, or which spreads to the dermal lymphatics. So dermal lymphatics, if blocked, causes the distal part of the lymphatics to swell and form an erythematous itchy rash with skin texture changes, which looks similar to an orange peel. Therefore, cancer or inflammatory breast cancers usually manifest as pudiorin's appearance. Okay. 1 to 9%. So 1 to 9% of Caucasians worldwide are heterozygous carrier of factor V leading mutant, factor V mutant. So 1 to 9% of Caucasians. So Caucasians in the West are heterozygous carriers of factor V leading, which is more modded to resist activated protein C. So protein C is actually an anticoagulant molecule. So it prevents coagulation. So protein C, when activated, prevents coagulation. So factor V leading is something which resists the activated protein C. So it causes more. So you see, factor mutation causes decrease in the activity of protein C. So in decrease in the activity of anticoagulation, that is, more coagulation occurs. So therefore, factor V leading mutation causes hypocoagulable state, which predisposes to DVT, which is the source of most pulmonary embolisms. Okay, saddle pulmonary embolism straddles. So saddle pulmonary embolism, which occurs in the main pulmonary artery, straddles the bifurcation of the main pulmonary artery, VTA, that is venous thromboembolism. That is, venous means deep vein. So deep vein thrombosis and pulmonary embolism arises due to Wernicke's triad of endothelial injury, venous stasis, and hypocoagulable state. So malignancy causes a hypocoagulable state and is a strong risk factor for venous thromboembolism. So malignancy must always be thought while we see a case of deep vein thrombosis. So deep vein thrombosis, thrombus formation in malignancy is as a result of cytokines which causes endothelial injury, venous stasis, or the stasis of the blood, and a hypercoagulated state. So cell pulmonary embolism must be always ruled out. So it is the result of DVT or deep vein thrombosis. So now next point is all about 6-mercaptopurine. So 6-MTP. So 6-mercaptopurine is mainly degraded in the liver by xanthine oxidase. So xanthine oxidase. So there's an enzyme in the liver. So see, there's a liver. There's a liver. So let's draw a liver. So there's a liver with an enzyme XO. So there's an enzyme in the liver, XO enzyme in the liver. So 6-mercaptopurine when taken by the liver forms a compound. Okay, allopurinol. So allopurinol acts on the level of xanthine oxidase, which is present in the liver. So it increases, which when inhibited. So if xanthine oxidase is inhibited by allopurinol, then 6-mercaptopurine's concentration in the blood rises. 6-mercaptopurine's concentration in the blood rises. So 6-mercaptopurine and 6 TZ are products that require activation by HZPRT. So HZPRT, so they are products which require activation by HZPRT. So HZPRT needs to act on 6-mercaptopurine and 6 TZ, and only their function can occur. So this is how this point, that is what this point means. So now next point is about HZPRT. So HZPRT is also a very important enzyme in various especially in uric acid metabolism. HZPRT and 6-mercaptopurine. Okay, let me search about 6-mercaptopurine and HZPRT. Okay, all right. I'll share you what I find. So okay, 6-mercaptopurine competes with the purine derivative hypoxanthine and guanine for the enzymes NCPRT and is itself converted to TIMP, thioinosine monophosphate. Okay, so they compete. 6-mercaptopurine and compounds, they use NCPRT. So they use NCPRT. Therefore, NCPRT, which is generally used to prevent convert xanthine use of NCPRT, which is used. Okay, I don't think that I understood well. Mercaptopurine. So 6-mercaptopurine competes with hypoxanthine and guanine, which are purine-derived structures for the NCPRT. So purine-derived structures. What are the purine-derived structures? Hypoxanthine and guanine. So hypoxanthine and guanine, GNH, hypoxanthine and guanine and hypoxanthine are purine-derived derivatives which require NCPRT. But 6-mercaptopurine competes for NCPRT, and then 6-mercaptopurine converts to thioinosine inosine monophosphate (TIMP), and TIMP inhibits the conversion of inositolic acid to xanthalic acid and adenalic acid through adenyl succinate. So let me not bother you much by the facts, similar facts. Let's move on to the next point. So methotrexate and 5-fluorouracil. So methotrexate and 5-fluorouracil both effectively inhibit thymidylate formation. So thymidylate formation is inhibited by methotrexate and 5-fluorouracil. So it inhibits methotrexate inhibits DSFR, so dihydrofolate reductase. So DSFR when inhibited decreases the formation of thymidylate, which is essential for DNA synthesis or replication. So what the chemotherapy effect of methotrexate is overcome by so it inhibits the formation of folic acid. So when folic acid is given, or when folic acid is given by N5 in the form of N5-formyl THF, tetrahydrofolate. So tetrahydrofolate is not formed because of methotrexate, so DNA synthesis is impaired. So addition of or supplementation of N5-formyl, N5, so fifth carbon atom, so number 5, fifth carbon atom formyl tetrahydrofolate bypasses that inhibitory step, and the byproduct is formed. Thereby doesn't, when added, like folic acid and leucoperin, when added into the compounds together with methotrexate, prevents excessive DNA damage, and rather helps in countering the side effects of methotrexate. Okay, the vinca alkaloids. So vinca alkaloids are cell cycle specific agents that prevent proper separation of chromosome into daughter cells during the M phase of the cell cycle. So in the cell cycle metaphase of the cell cycle, there has to the sister chromatids has to separate and move towards the respective chromatid, so respective centrioles. But vinca alkaloid stabilizes it, and therefore it does not move towards the opposite poles, and anaphase does not occur. So the main dose-limiting adverse effect of vincristine is neurotoxicity, and neurotoxicity is a very common side effect of. So this separation does not occur even in the axons of the neurons, and therefore it results in peripheral neuropathy. So neurotoxicity is the dose-limiting effect of vincristine therapy. So as discussed above, neurotoxicity is the dose-limiting. So So if the dose is adjusted, then neurotoxic can be prevented. So it's a dose limiting adversity of beta-glucan therapy. This toxicity results from failure of microtubule polymerization in neural axons. So neurotoxicity of vincristine therapy. So vinca alkaloids. So vinca alkaloids. Okay. I mistook. So okay. Vinca alkaloids. So vinca alkaloids. All right. So vinca alkaloids, or let's say vincristine, prevents this toxicity prevents from failure of microtubule polymerization in the neural axons. So in the neural axons, there is no microtubule polymerization, and other notable adverse effects classically are associated with chemotherapeutic agents include flagellate skin discoloration with pulmonary fibrosis and flagellate skin discoloration with bleomycin use. So bleomycin is actually an antibiotic. So it is an antimicrobial compound that can be used as a chemotherapeutic agent as well, but it causes a dangerous pulmonary fibrosis and flagellate skin discoloration. And congestive heart failure occurs with doxorubicin. So C and D come together. So doxorubicin causes congestive heart failure, and hemorrhagic cystitis occur with cyclophosphamide. A normal bleeding time indicates adequate platelet hemostatic function. So hemostatic function of platelet is normal. A normal APDT indicates an intact intrinsic coagulation system. Prolonged PT in the setting of normal APDT indicates a defect in the extrinsic coagulation system at a state that is not shared with the intrinsic system. Okay, this is a very understandable point. And let's move on to the next point. All right. Okay, exertional dyspnea, pneumonia in life-threatening acute coronary syndrome. So if there is life-threatening acute coronary syndrome, exertional dyspnea, pneumonia can occur, and recurrent abdominal and bone pain are clinical features of sickle cell anemia. So if there is sickle cell anemia, there is sickling, which results in blockage of blood supply to the particular organ. So exertional dyspnea, pneumonia, such as in acute coronary syndrome because of spasm of the blood vessel or narrowing of the blood vessel by the sickling of RBCs, and recurrent abdominal and bone pain, so bony crisis, are the results of SCA. SCA results from a point 26 that causes failure to substitute for glutamic acid in the sixth position of the beta globin chain of the hemoglobin. That is well understood. The next point, follicular lymphoma is a non-Hodgkin's lymphoma, follicular B lymphocytes. So in the follicular B lymphocytes, follicular lymphoma can occur. Patients with follicular lymphoma characteristically have a translocation between chromosomes 14 and 18, which causes BCL2 overexpression. So translocation between 14 and 18 occur, which causes BCL2 overexpression. So BCL2 is considered a proto-oncogene with anti-apoptotic effects. So BCL2 is actually a proto-oncogene with BCL2 is an anti-apoptotic protein. So which when released in the cytoplasm because of any damage leads to caspase activation and resulting apoptosis. Follicular lymphoma is a non-Hodgkin's lymphoma, follicular B lymphocytes. Patients with follicular lymphoma characteristically have a translocation between chromosome 14 and 18. So follicular lymphoma has translocation between chromosome 14 and chromosome 18. So which causes BCL2 for overexpression. So chromosome 14 has BCL2, which moves to the immunoglobulin heavy chain in the chromosome of 18, and there is overexpression of the BCL2, which protects cancer cells from apoptosis. Von Willebrand disease is the most common inherited bleeding disorder. So it is a most common inherited bleeding disorder. It is an autosomal von Willebrand disease. The name itself is so dominant, so there is a dominant pattern, autosomal dominant pattern of inheritance and variable penetrance. Von Willebrand disease is the most common inherited bleeding disorder. And the name is itself very dominant, so it is an autosomal dominant pattern. It has the autosomal dominant pattern of inheritance and variable penetrance. Absence of one factor leads to impaired platelet function, and therefore it increases bleeding time and coagulation pathway abnormality due to decreased factor 8 activity. So one factor and factor 8 both decreases, therefore PTT increase, BT increases, however not the extrinsic PT. Hopefully. Okay, so beta thalassemia is caused by mutations that result in defective transcription, processing, and translation of beta globin mRNA. So beta thalassemia occurs because of defective translation. So splicing defect occurs. Therefore, translational effect and beta globin mRNA is not formed. This is a deficiency of beta globin chains recover normal hemoglobin synthesis. So normal hemoglobin synthesis does not occur because of absent beta globin chain. Okay. Renal cortical cells sense hypoxia and respond by synthesizing and releasing EPO, that is erythropoietin, and erythropoietin stimulates the production of erythrocytes in the bone marrow. So mostly renal cortical cells, not the medullary cells. Renal cortex, the outer part of the kidney, has some cells which can sense the decrease in oxygen, that is hypoxia, and in turn can release erythropoietin. Erythropoietin increases the amount of RBC production in the bone marrow, and that is it. So hemophilia is an X-linked recessive coagulopathy that manifests with intramuscular hemorrhage. So there is arthrosis, hemarthrosis occurs, delayed bleeding after procedures, and lab abnormalities shows PTT prolongation because factor 8 and 9 is deficient. So factor 9 and 10 is deficient. So PTT, which represents intrinsic pathway, is increased, and other tests of hemostatic functions are generally normal. So PTT is prolonged, and other tests of hemostatic functions are generally normal. So other tests are normal. So autoimmune platelet destruction is a common cause of thrombocytopenia and should be suspected in patients with ecchymosis pericarditis, mucosal bleeding, and no other obvious causes of thrombocytopenia. Example: treatment, bone marrow failure, etc. So autoimmune platelet destruction. So platelets are destroyed by the immune system itself because of it. Platelets, decreased platelet causes thrombocytopenia, and thrombocytopenia causes ecchymosis, petechiae, mucosal bleeding, and no other obvious cause of thrombocytopenia. If there is no other obvious cause of thrombocytopenia, then autoimmune attack to the platelets must be suspected. APM, that is acute promyelocytic leukemia, can present with persistent infection and coagulopathy causing hemorrhagic signs and symptoms. So if there is persistent infection and persistent coagulopathy, and some hemorrhagic features, then EPML must be suspected. Bone marrow biopsy classically reveals promyelocytes with intracytoplasmic rods. So bone marrow biopsy reveals promyelocytic, therefore it's a promyelocytic leukemia, and EPML is associated with a translocation 1517 that causes fusion of a RARA alpha. So RARA alpha gene with and PML gene. So promyelocytic gene and RARA alpha gene from chromosome 15, which holds RARA alpha, goes to chromosome 17 with PML, resulting in APML. Okay. The finding of high peak in the gamma globulin region in SPP, so electrophoresis. So if in the electrophoresis there is high peak in the gamma globulin region, so gamma globulin region, if there is a high peak in the gamma globulin region in serum electrophoresis, it represents an M protein consisting of an overproduced monoclonal immunoglobulin. So monoclonal immunoglobulin, if increases, produces an M spike pattern in electrophoresis, which has a high peak in the gamma globulin region. So in the gamma globulin region, there is a peak. So there is a high peak in the gamma globulin region. So not in the alpha globulin region, but in the gamma globulin region. Gamma means gamma globulins means immunoglobulins. So because of overproduced monoclonal immunoglobulins, there is spike in the gamma globulin region, which represents an M protein. So in multiple myeloma, there occurs M protein peak on SPIP, as well as anemia, weakness, lytic bone lesions, back pain, pathological factors, and renal insufficiency related to amyloid deposition and hypercalcemia. So renal insufficiency occurs because of amyloidosis and hypercalcemia, and lytic bone lesions occurs. So there is radiolucency. Alright, so etoposide. So etoposide is a chemotherapeutic agent that inhibits the sealing activity of topoisomerase 2. So etoposide inhibits topoisomerase 2. So topoisomerase 2 has two domains, and the second domain represents ligase function. So ligase is cut off. So ligase domain is cut off. Therefore, the high supercoiling supercoiling after being cut by the first domain of topoisomerase 2 cannot be sealed off because the ligase domain is cut off. Therefore, treatment with etoposide causes chromosomal breaks, which to accumulate in dividing cells, ultimately causing cell death. So when etoposide is given, then it causes chromosomal breaks to accumulate in dividing cells. So there is constant chromosomal breaks, and which cannot be ligated after the supercoils are released. Device cell death occurs. Etoposide occurs via this mechanism. The sequence of amino acids in the growing polypeptide chain is dictated by the interaction of the mRNA codon with the tRNA anticodon. So mRNA codon and tRNA anticodon represents or dictates the sequence of amino acids. So which amino acid is produced is dictated by the mRNA codon, which forms a corresponding tRNA anticodon, and amino acid is formed in the growing polypeptide chain tRNA that's mischarged with the incorrect amino acid and not corrected by amino acid tRNA synthesis proofreading. So tRNA has some tRNA has anticodons, and anticodons represent an amino acid. So if there is no correction of the anticodons, that is, if there is no correction of the amino sorry yeah, so there are no correction of the amino acid by amino acid tRNA synthesis, amino acid tRNA synthesis proofreading. So it will incorporate wrong amino acid in the growing polypeptide chain. So tRNA has anticodons, which has to be proofread by tRNA synthesis proofreading activity. So anticodon has, if malfunctions or has the wrong kinds of anti-amino acids or the codons, then the mRNA will synthesize, mRNA with its codon will synthesize a different amino acid in the while the growing polypeptide chain continues. And therefore, wrong amino acid is formed, which results in, malfunctioning of the protein so formed. The nucleolus at the site of ribosomal subunit maturation and assembly. So nucleolus, what is a nucleolus? So nucleus is the dot, or the central. It is present inside the nucleus in the site of ribosomal subunit maturation and assembly. So ribosomes, all the ribosomal subunits, 60 years, 40 years, all the ribosomal subunits come together, assemble and mature into bigger form of ribosome. So nucleus is the site of ribosome subunit maturation and assembly. RNA polymerase 1. So RNA polymerase 1. So RNA polymerase 1 functions exclusively within the nucleolus to transcribe the 45S pre-RNA gene. So pre-rRNA gene. So for RNA polymerase 1. So what is the function of RNA polymerase 1? So nucleolus means where all the ribosomes of 60S, 45S, 428S, 5.8S, 18S, all the ribosomes subunit come together, assemble and mature in the nucleolus. So RNA polymerase 1. So RNA polymerase 1 is an enzyme which functions exclusively within the nucleolus. So how does the cell determine which 50 years or 40 years or 40 years or 60 years which subunit of the ribosomes must be compiled or assembled? So it occurs via RNA polymerase 1 enzyme. So RNA polymerase 1 functions within the nucleolus to transcribe the so there is transcription of 45S. This is a subunit of ribosome. So 45S pre-rRNA gene. So transcription of 45 pre-rRNA gene occurs inside the nucleolus by the enzyme RNA polymerase 1. So RNA polymerase 1 helps in the transcription of 45S pre-rRNA gene, which codes for most of the ribosomal RNA components. So ribosomal RNA components, 45S pre-rRNA genes codes for the components of other RNA, ribosomal RNA, RNAs, which is 18S, 5.8S, 28S, 18 and 28, 5.8. So 18 plus 10, which is like 5.8. So 18S Svedberg's units, 5.8S and 28S are RNAs. All right, sickle cell anemia. So now let's talk about sickle cell anemia. Sickle cell anemia is an autosomal recessive hemoglobinopathy. Sickle cell anemia is an autosomal recessive hemoglobinopathy. Sickle cell anemia is an autosomal recessive hemoglobinopathy. So it is an autosomal recessive condition. It is an autosomal recessive condition. In order for a child to have a sickle cell disease, both parents must be carriers. So both parents must be carriers for the child to have sickle cell disease, because it is an autosomal recessive condition, and if one parent has autosomal dominant or both the chromosomes right, then it cannot be transferred to a baby. So the baby can be carriers but cannot be diseased. So hemoglobin electrophoresis can be used to determine the carrier status of the prospective parent who has no history of sickle cell anemia. So even though there is no history of sickle cell anemia in the parents, the carrier state of the parents or the child can be determined by using hemoglobin electrophoresis. All right, Western blotting. Western blotting is used to identify proteins. So Western blotting. So in the West, they synthesize a lot of proteins. Northern blotting identifies specific RNA sequences. So in the north, so in Russia, let's say, there is RNA sequences are identified. So RNA synthesis occurs in Russia, that is R starts with R. So RNA synthesis starts with R. So in the northern side of the planet, northern blotting identifies specific RNA sequence. Western blotting synthesizes proteins, identifies proteins, and southern blotting identifies specific DNA sequence. So north is for RNA, south is for DNA sequence in an unknown sample. So north RNA identification of specific DNA sequences occur in the southern blotting, and western blotting is for proteins. Now, next point is about PCR. PCR is used to amplify small fragments of DNA, that is genes, exons, non-coding regions, so genes in the DNA, the exons in the DNA, not introns but exons in the DNA, and the non-coding regions by repeated replication. So PCR PCR is used to amplify small fragments of DNA with genes, exons, non-coding regions by repeated replication. It requires primers that are complementary to the regions of DNA flanking the segment of interest. So it requires primers. So for PCR, polymerase chain reaction, to multiply the DNAs, to multiply fragments, it requires some small primers that are complementary to the regions of DNA flanking the segment of interest. So the part of DNA, the segments of DNA, which is the single most important point to be multiplied, the complementary primers have to be added. So required primers which are complementary to the regions of DNA flanking the segment of interest are taken. Thermostable DNA polymerase, D-NTP, so nitrogenous compound. So DNA polymerase. So DNA polymerase is given to so as the primers attach and helps in the replication of the DNA fragments. DNA polymerase, thermostable DNA polymerase, D-NTPs, and source of DNA template strand are also necessary. So a source of DNA template strand. So DNA template strand, DNTPs, which helps in the formation of DNAs, and DNA polymerase. All three. So DNA polymerase, DNTPs, and deoxyNTPs, and the source of DNA template strand are also necessary. Now, sickle cell disease is characterized by repeated splenic infarction that ultimately results in splenic atrophy and fibrosis, a process that's typically completed by late childhood or adolescence. After autosplenectomy, patients are predisposed to infection with encapsulated bacterial organisms. Understood, and MCV more than 110 cubic millimeters cube is highly suggestive of megaloblastic anemia, such as that caused by vitamin B9 or B12 deficiency. So B12 deficiency, folic acid of B12 deficiency, megaloblastic anemia more than 100 MCV. So patients with chronic hemolytic anemia have high amount of vitamin B9. So chronic hemolytic anemia have high amount of chronic hemolytic anemia. So there is hemolysis occurring for a long period of time, have high vitamin B9. So requirement of folic acid is high in patients with chronic hemolytic anemia due to high erythrocyte turnover, which are predisposed to develop macrocytosis. So see, chronic hemolytic anemia. So chronic hemolytic anemia requires more amount of folic acid. So chronic hemolytic anemia require high amount of folic acid. So chronic hemolytic anemia require high amount of folic acid. So due to high erythrocyte turnover and predisposition to develop macrocytosis. Alright, so patients with chronic hemolytic anemia have high vitamin B9 requirement. Okay, not B12. So if there is hemolysis, then there is destruction of RBCs. To form more RBCs, more folic acid is required, because folic acid helps the formation of thymidylate, which is an important component of the DNA segments for the development of RBCs or erythrocytes. Therefore, so vitamin B9 requirement is high. All right, now, this is one of the most difficult concepts to understand: the Kozak consensus sequence. The Kozak consensus sequence occurs on eukaryotic mRNA. So there is an mRNA in the eukaryotes, not in the prokaryotes, but in the eukaryotes with the nucleus. There is something called mRNA. mRNA is present in the nucleus of an eukaryotic cell. So the mRNA is present in the Kozak consensus sequence. So there is in the mRNA there is something called Kozak consensus sequence, was defined by the following sequence. So the sequence is, so before AUZ, before methionine AUZ, there is a Kozak sequence which is GCC RCC, in which R is either adenine or guanine. So R means A or Z. So GCC RCC, R represents A or Z. So this is called the Kozak consensus sequence, in which R is either adenine or guanine. So this sequence helps initiate translation at the methionine start codon. So this sequence is necessary. So we are always taught that AUZ represents methionine, and the translational activity from the mRNA occurs from the AUG sequence. But before AUG sequence, there is something called Kozak consensus sequence. There has to be some consensus between tRNA and mRNA while translating proteins. Therefore, this consensus sequence is this RCC. So R represents A or Z. So ACC or GCC must be present before A or Z for methionine to start coding, for A or Z to start coding methionine. Okay, now let's talk about beta thalassemia. Beta thalassemia results in hypochromic microcytic anemia due to decreased beta globin chain synthesis. Unpaired alpha chains precipitate within red cells and cause membrane damage, leading to ineffective erythropoiesis and extravascular hemolysis. So beta thalassemia results in hypochromic microcytic anemia. So beta thalassemia results in it's a cause of heredity. So it's called microcytic anemia. So microcytic hypochromic anemia occurs because of decreased beta globin synthesis. Now, unpaired alpha chains. So there is beta decrease in beta globins, therefore alpha globins increase, and unpaired alpha chains precipitate within red cells. So those alpha 4, alpha 4 are formed in beta thalassemia, and they precipitate inside the red cells and cause membrane damage. So membrane ruptures, thereby causing hemolysis, extravascular hemolysis occur not within the blood vessel, but because the cell membrane defect is present, then the spleen's macrophage cause destruction of the RBCs, hence causing extravascular hemolysis and ineffective erythropoiesis as well. Now, cytokeratin. So cytokeratin is a common use immunohistochemistry marker of epithelial cell carcinoma. So in epithelial cell carcinomas, cytokeratin is commonly used. So epithelium. So there's keratin, so which represents epithelium. So cellular keratin is commonly as a marker of epithelial cell carcinomas. Okay. Next point is about HER2 oncogene. So HER2 oncogene codes for a transmembrane glycoprotein with intrinsic tyrosine kinase activity. So this is a cell. You see, this is a cell. This is a cell. This is a cell. Then the red thing in the cell represents a tyrosine kinase function. So this is tyrosine. This is K tyrosine kinase function. So HER2. There is something called HER2. S for H, E for E, R for R, HER2. So this is HER2 oncogene, which codes for transmembrane glycoprotein. This is a transmembrane glycoprotein which has intrinsic tyrosine kinase activity, and is a member of the family EGFR. So epithelial growth factor receptor. So this is an example. HER2 is an example of HER2 binds codes for transmembrane glycoprotein, which has intrinsic tyrosine kinase activity, and is a family. It falls under a family of EGFR. So epithelial growth factors receptors. So overexpression of this protein is associated with worse prognosis and increased risk of disease recurrence. So overexpression of this protein, tyrosine kinase protein, if overexpressed, results in increased disease recurrence. So recurrence of this disease is high. So if there is high overexpression of this protein, so this protein, if it's overexpressed, represents worse prognosis and increased recurrence of the disease. So prognosis of the cell is bad, as well as recurrence of the cell is bad. So there is more recurrence, chance of recurrence. Okay. All right. 4 more pages to go, buddies. Next point. Patients with von Willebrand disease often present with a lifelong history of mucosal bleeding, including gingival bleeding, epistaxis, short menorrhagia. These patients have normal platelet levels, but typically have a prolonged BT due to impaired platelet function. This is a qualitative defect. It was discussed multiple times before. Von Willebrand factor functions as a promoter of the platelet adhesion at sites of vascular injury. So von Willebrand factor functions as a promoter of platelet adhesions. So it functions for platelet adhesion by ZP1B. By the platelets with ZP1B receptor bind to the collagens that are exposed by von Willebrand factors at the site of vascular injury by binding platelet ZP glycoproteins to subendothelial collagen on end blood vessel walls. It also acts as a protective carrier protein for circulating factor VIII. So it also acts as a protective carrier protein. So factor VIII is carried by von Willebrand factors. All right. So next point is about both unfractionated hemoglobin and low molecular weight heparin. So the unfractionated as well as low molecular weight heparins can bind to endosomal 3 due to its activity against factor 10A. So factor 10A, the factor 10A. So it binds to endothelin 3, so it's 83 endothelin 3 to increase its activity against factor 10A. So factor 10A, which is clotting factor, is reduced. The functioning of the factor 10 is reduced, but only unfractionated heparin is able to bind to both both 83, so endothelin 3, and factor 2A to allow antithrombin 3 to inactivate factor 2A. Okay, so the difference between low molecular weight heparins and unfractionated heparins is low molecular weight heparins directly, inhibit factor 10A, while unfractionated heparin first can bind to both antithrombin 3 as well as factor 2A. Activated factor 2A means thrombin, so I can bind to thrombin as well as antithrombin 3 to allow antithrombin 3 to inactivate factor 2A. So thrombin is not formed, so therefore there is more coagulation and more chance of bleeding, more chance of more or blood thinning. Okay, so factor 10A inhibitors. So factor 10A inhibitors, apixaban, rivaroxaban, increase the PT and ability but doesn't affect the bleeding time. So the factor 10 is a common coagulation pathway, so increases both PT and ability but does not affect the site, doesn't affect PT on fractional heparin and direct thrombin inhibitors. So direct thrombin inhibitors, for example, dabigatran. So direct dabigatran is direct thrombin inhibitor prolong the TT. So what is TT? Is it thrombin time? No idea. Okay, I had supposed. Oh yeah. Maybe on fractional heparins and direct thrombin inhibitors. So because thrombin is inhibited, it can increase the thrombin time. Makes sense now. Multiple myeloma is associated with circulating paraproteins, monoclonal immunoglobulins, which cause erythrocytes to stack like coins. So, multiple myeloma is associated with. So, in multiple myeloma, there is monoclonal proliferation of monoclonal immunoglobulins, which causes erythrocyte to stack like coins. So there are multiple immunoglobulins, and those immunoglobulins bind to the RBCs, which forms rouleau. Patients classically have normocytic anemia, hypercalcemia, bone pain, and renal insufficiency, given by the code CRAB. Okay, C represents for calcium, R represents for renal insufficiency, A represents for anemia, normocytic anemia. So it's normocytic anemia, okay? And B represents for bone pain. The primary immune response to Epstein-Barr virus is mediated by CD8 T lymphocytes. So CD8 natural killer cells come to kill Epstein-Barr virus, which are activated through the presentation of viral antigens on infected CD21 plus B lymphocytes. So which are activated through the presentation of viral antigens on infected CD21 plus B lymphocytes. So, okay, so CD8 cells, T lymphocytes are activated. How does EBV triggers natural killer cells to eat them? So when virus enters the body, so see, viral antigens infect the CD21 plus B lymphocytes. CD21 plus B lymphocytes now stimulates CD8. 21 stimulates 8 T lymphocytes. 21 B lymphocyte stimulates 8 T lymphocytes. Alright, this reactive or typical CD8 plus T lymphocyte can be observed in the peripheral blood smears of patients with IM infectious mononucleosis. So these typical or reactive CD8 plus T lymphocytes can be observed in the peripheral blood smears. So in PBS, these reactive or atypical CD8 plus T lymphocytes can be seen. Alright, so with maternal blood types A or B, so A and B, what is SDFN? I think it's hydros fetalis. No. SDFN. I know what SDFN is, but I cannot say its full form now. SDFN very rarely occurs because maternal antibodies anti-A or anti-B are of the IgM type and can't cross the placenta. In contrast, mothers with blood group O also produce IgZ antibodies, anti-A and anti-B, which can cross the placenta and cause fetal hemolysis, thus causing hydros fetalis. Okay, so here also if the maternal blood groups type A and B, see. So see, the baby's blood is not destroyed, or there is no hemolysis of the baby's blood. If the baby is, if the mother has blood group of A or B, because A or B, anti-A or anti-B present in the mother's blood are of IgM type and can't cross the placenta. But those with O blood group mother has Z families of antibody which can cross the placenta and cause fetal hemolysis. Okay, alternate splicing is a process where the exons of a gene are reconnected in multiple ways during PTP, post-translational I'm not sure what PTP is. Splicing is a process in which the exons of gene are reconnected in multiple ways during PTP. So alternate splicing and PTP. What's the full form of PTP? I'm not sure. Alternate splicing and PTP. PTP delta or receptor tyrosine phosphatase. I think it's just a receptor. It's a very difficult concept, so just know it as PTP. So okay, so gene. So exons of a gene are reconnected. So exons of a gene are reconnected in multiple ways during post-translational post-translational proteins. This creates a different mRNA sequence and subsequence, different protein isoforms. It's a normal phenomenon in eukaryotes that greatly increase the biodiversity of proteins encoded by the genome. So it is a normal phenomenon in eukaryotes that greatly increases the biodiversity of proteins encoded by the genome. Okay, so biodiversity of the proteins, isoforms, various isoforms of the proteins are formed. And therefore, this creates a different mRNA sequence and subsequence, different protein isoforms, and increases the biodiversity of proteins. All right. Some patients with non-squamous cell large cell. So what's this? What's this, baby? What's this, baby? Some patients with some patients with NSCLC. So what is NS? Non-squamous CLC. NSCLC, non-small cell lung cancer. So non-small cell lung cancer harbor a chromosomal rearrangement that creates a fusion gene between EML4 and ALK. So EML4 and ALK fusion gene is formed in non-small cell lung cancer. So in non-small cell lung cancer, then EML4, this side is E, so EML4 and ALK, A and E, AE combines, or fusion gene is formed. This results in a constitutive active tyrosine kinase that causes malignancy. All right. Inflammation is characterized by the passage of circulating inflammatory leukocytes into the inflamed tissue. So circulating inflamed leukocytes enter the inflamed tissue, which causes inflammation. The steps involved include, so first the activated leukocytes come to the margin of the endothelium. So margination occurs, there it rolls, so rolling occurs and it activates. So then it activates and releases integrin receptors. It then binds, tight adhesion occurs, and then crawls and transmigrates through the cells. So inflammation that produces passes of activated leukocytes into the inflamed tissue. So the steps include margination occurs, rolling occurs, activation occurs, and then attachment occurs, or adhesion occurs, crawling occurs, and transmigration occurs. Adhesion, crawling, and transmigration are these steps of inflammation. So DZS syndrome causes an extreme deficiency in the number of mature T lymphocytes, leading to poor development of lymph node paracortex. DZS syndrome, DZS. So what is DZS? DZS. So what is DZS? DZS. What is DZS syndrome? DZS syndrome. Yeah, DZS is a primary immunodeficiency disease. So it is a PIDD, means primary immunodeficiency disease. So there is decreased T cell production and function. So decreased T cell production and function due to thymus, lack of thymic maturation. So poorly developed thymus. So thymus is cool. So the maturation of T cells are in thymus. So if there is less thymus or inactivated or decreased T cell form, small thymus or poorly developed thymus, then T cell maturation does not occur. So there is deficiency in the maturation of T lymphocytes, leading to poor development of the lymph node paracortex. So paracortex has T cells. So paracortex, the T cells in the paracortex does not develop. In contrast, all-globulinemia causes an absence of B cells. So all-gamma-globulinemia. So Bruton's all-gamma-globulinemia. So X-linked Bruton's all-gamma-globulinemia cause an absence of B cells, which is preventing primary lymph node follicles and germinal centers from forming in the lymph node cortex. So lymph node cortex with various lymph node follicles which has germinal centers within it. Okay, so those germinal centers are affected in all-gamma-globulinemia because of absence of B cells. Okay, so now the chronic myeloproliferative disorder, that is polycythemia vera, essential thrombocytosis, and primary myelofibrosis. The chronic myeloproliferative disorders often have a mutation of JAK2 or cytoplasmic tyrosine kinase activity. So this results in constitutive tyrosine kinase activity and consequently in the cytokine independent activation of STAT protein. So the STAT signaling pathway is stimulated. Okay, that's an easy topic. TLS, tumor lysis syndrome, can develop during chemotherapeutic treatment for cancers with rapid cell turnover, that is poorly differentiated lymphomas and leukemia. So poorly differentiated lymphomas. So lymphomas, the collection, the multiplication of lymph node cells, lymphocytes, cause lymphomas. So if they are poorly differentiated lymphomas or leukemias, substantial tumor burden or high sensitivity to chemotherapeutic agents, then there occurs tumor lysis syndrome. It is characterized by hyperphosphate. So inside the cell there is phosphate, calcium, phosphate. So phosphate is released, and the you know the albumin components from into the cell binds to the calcium, therefore it is causing hypocalcemia. Cells has potassium, so hyperkalemia occurs. Cells has various proteins which form uric acid, so hyperuricemia occurs. So only decreasing electrolyte is calcium. So hyperphosphatemia, hypocalcemia, hyperkalemia, and hyperuricemia occurs. Prevention often involves hydration and the use of hypouric. So water has to be given, and the use of uricemic agents such as allopurinol or raspuricase. So raspuricase or allopurinol can be given. All right, let's stop here, and the rest of the 5 pages will be discussed later. Thank you so much, guys. Keep supporting. Bye bye.